Also, I definitely forgot to start recording. So sorry to
Oh, do I have to say
anyone
that
watching the
again? No, I'm
recording.
kidding.
No, it's fine. All good. Anyway, yeah, think about the pleura. Go revise your anatomy, basically.
Yes.
Okay, let's keep going. But well done. Majority of you guys got that one correct. Right. The classic sinusoidal dissociation curve. Okay, good.
Well
So
done.
yeah, what's our main little thing? So people are thinking, okay, people are thinking increased PO2 or increased ATP. So I guess the way to think about it is basically whenever your body is working really hard, you want more oxygen. So everything that is created when your body works hard causes the oxygen dissociation curve to shift. So your body sees, think of it like a muscle, sort of region of muscle. Your body's like, okay, well, the pH has gone down because we're making lactic acid. The temperature has gone up because we're doing activity. We're getting more CO2 because we're doing a lot of respiration. So we're going to put more oxygen into this area. The 2-3 DPGs, you just sort of have to memorize that. But that's basic idea. And so like, if you think about it, we wouldn't expect to see more oxygen when the PO2 increases, because that sort of tells you there's already enough oxygen, if that makes sense. But yeah.
Another just easy way to remember this is you definitely think about it as like, oh, if it goes to the right, then it's kind of the things that happen during exercise. But if you want to keep it really simple, you can just think that if it goes to the right, everything increases. So when I say that, I mean increase in temperature, increase in 2-3 DPG. And the tricky one that a lot of people get mixed up on is increased H plus. So increased H plus actually leads to a decrease in pH, hence why it says decreased pH. But in short, everything increases when you go to the right, everything decreases when you go to the left, if that makes sense.
Yeah, perfect. All right, we have a lot of movement. Who knows what will happen? You guys had me worried there for a second. I was like, has it lagged out? Okay, we're good. Oh boy. Okay. So we have some interesting ideas here. So the basic idea with this, did you write this one, Jana, at all?
I did not. And to be honest, if I saw this question, I probably would have failed as well, because it's essentially like you just need to know what this breathing cycle graph looks like and how interpleural,
Yeah.
interpulmonary, like, or how do they all change with the breathing cycle? So
Yeah.
like, if you know it, you know it. If you don't know it, you don't know it.
Yeah.
But
I
it's
guess
a good signal to revise.
yeah, the way I think of it, everything is a good signal to revise. But the way I think about it is sort of, remember the pleura have to then push, like, you know, interpleural pressure. That's sort of when it lowers, it's pulling stuff in. When it raises, it's pushing stuff out. Whereas if intrapulmonary pressure is high, that's just saying you have a lot of air in the lungs. That doesn't mean anything. And so we'd actually expect it to, we wouldn't expect it to rise during expiration, whereas intrapleural pressure should rise. Okay. All right. Still a lot of movement. Anyone's game at question 4 out of 61. Nice. Okay. We're pretty happy with this one. I think it's pretty self-explanatory. So you get old, your lungs are all, you know, stiff. Pulmonary fibrosis, same thing. SNS will also make it. So your parasympathetics might make it more compliant. But surfactant is the really big thing. And of course, if you don't have surfactant, then you have a lot of problems with breathing. I'm aware that we like this big Kahoots take ages. I'm going to try and speed through the ones where we all get it right. just as a bonus, is anyone able to chuck in chat what the other thing we'd be concerned about, or the primary other thing? Like a lot of these are sort of hinting at a different diagnosis, which we might expect to see. Yeah, somebody said TB, perfect, tuberculosis. So tuberculosis and cancer are like almost the same presentation. Like they come in, they've got weight loss, they've got hemoptysis, they've got difficulty breathing. And so recent travel, so just like working through these, the other three are all like TB things. So recent travel history, because you get it more often overseas. The MAN2 test, which I suspect many of us forgot what it was, which is fair because I also would have forgotten what it was in year 2. That's a TB test. So if it's positive, then you have TB, not cancer. Duration less than 2 weeks, that's thinking about how acute versus chronic it might be. So it might develop more slowly. And normal white cell count. So if there's no immune response, then it's more likely that it's a cancer. Okay. Yeah. So that really just comes down to differentiating between the two. No comment on chosen usernames. Okay, nice. We're all pretty comfortable with this one. Just as a side note, like often when you you have something viral, it's less likely that you'll recommend treatment because viral treatment is more involved than bacterial treatment. Of course, you know, if you remember your microbiology, we also want to avoid overusing antibiotics in general, because otherwise we get resistance. But it's especially, you know, it's sort of futile if you want to put someone on big, expensive antiviral treatment for something pretty small. Easy. Okay, we definitely know a ripe, apparently. Anyone able to chuck in chat what the drug is? Like the one that has been incorrectly... Yeah, the one's missing out of our ripe. Which one has been... Yeah, somebody said ethambutol, perfect. Yeah. So rifampicin, isoniazid, pyrazinamide, and ethambutol. Erythromycin is just sort of a small broad spectrum antibiotic. Perfect.
Another just extra thing before we move on to the next one. Does anyone know what the one of the characteristic side effects are of taking a drug like rifampicin? Not necessarily like a bad thing. Yeah, exactly. Orange pee, red pee. In other words, kind of like reddish orange secretion. So it's not even pee. It can even just be like tears and stuff like that. So it's really important that you are able to distinguish that if a question comes up. Doubt it will. I don't think I remember seeing a question on it, but it's good to know that rifampicin does cause orange secretions. Well done.
Good stuff. All right, next one. About LABA usage. All right, good stuff. Quick bonus, anyone able to tell me, so I'll just run into blue and green. So beta agonists are positive inotropes. They increase the contractility of the heart. Anyone able to tell me which type? So there's beta 1 selective and beta 2 selective, and then non-selective. Which type of beta receptor, beta 1 or beta 2, is cardiac related? Yeah, good. Somebody said beta 1. So beta 1 receptors are the ones in your heart, and beta 2 in your lungs. You can remember it. You have one heart and you have 2 lungs. And so if you want to give someone, basically, if they have like heart failure or something, and you don't want to increase their contractility, but you do want to open up their airways, you give them something beta 2 selective. And they will give you side effects because they're pro-SNS, basically. Somebody says, does that mean beta antagonists are negative inotropes? If they act on beta 1 receptors, yes. So if you remember, like, yeah, like if you think back to hypertension, which I think we actually don't have too many hypertension questions in this Kahoot, so it's good that we touched on it. You have your ABCD, so your ACE inhibitors, your beta blockers, your calcium channel blockers, and your diuretics. So your beta blockers are there because they are negative inotropes. And in doing so, they'll decrease their contractility and they'll decrease your blood pressure. Okay, so they're definitely, absolutely the negative inotropes. And yeah, congrats to, I can't actually see the username, but thanks to whoever mentioned the SLUT effect. So it's just, you know, secretions, parasympathetic stuff. Really good, guys. Somebody said, why do we use beta blockers for heart failure? It's thinking about like preload, afterload, sort of. So it's sort of counterintuitive, but sometimes you'll want to do that. It's not usually a long-term thing. And I think usually you'd use them in patients with AF. So if they've got atrial fibrillation, it has some benefits for that. And so it's just sort of a useful drug. It's not a wonder drug for heart failure. But yeah. I apologize for this one. It's a lot of reading to do in 20 seconds.
I think I should apologize. I'm pretty sure this is the question that I wrote.
Yeah, I think it is one of yours, yeah.
Yeah, very good. So essentially with this question, I guess the other ones were kind of more normal findings. So if you're looking at red, it's supposed to be equidistant. If it wasn't, then that would be a pretty big red flag for tracheal deviation, something like potentially tension pneumothorax. And then you're not supposed to be able to feel the lymph nodes. It's pretty funny because like whenever we do like a full resp exam or a gastro exam, we kind of like make this big show of like, oh, I'm gonna look at this cervical chain, I'm gonna feel for all these nodes, but you don't actually feel anything. Like you never do until there's some sort of pathology like an infection or a cancer. What is the pathology described in yellow? Why did so many people pick yellow? What is the name of that pathology?
Good question.
Feel free to unmute as well if you, yeah, awesome. So Horner syndrome. And
Anyone
what is one of the, what are one of the like red flag causes of Horner syndrome? There's many causes, but yeah, Pancoast tumor. So apex of the lung tumor, and the fact that it's unilateral also gives it away that it's a cancer rather than some sort of systemic thing. Okay, very good. So that's why yellow is worrying.
Yeah, that's really good. That whole sort of concept is pretty high yield because it's just such a, you know, bright.
You'll come over it again as well in like head and neck. So remember to keep this in the back of your mind.
Yeah. All right. Okay,
oh boy.
Thinking about percussion.
This is not a music class, but here we go.
Right, good stuff. I think that one's pretty straightforward. The other, like red, yellow, and green are sort of rotated from what they should be. So resonant is a normal lung, dull is consolidation, and hyperresonant is a pneumothorax. And it's just like the more resonant it is, the more air there is in there. So we want a little bit of air. We don't want too much air, and we don't want too little air. All right, widening our lead at the top then. Still early days though. All right, hypercapnia. What do we expect to see?
Also have a think about what the other options mean. We won't go through each and every one of them, but just to have a think for your revision. Nice, well done. Can someone just really quickly chuck the name of what this is called in the chat?
Yeah, like the term for
the technical term. Yeah.
It is good in general to know both, because like for the exam, sometimes they'll give you a description and you'll have to figure it out. And sometimes they'll just give you the name and you have to figure it out from that. Yeah,
overwhelming response is asterixis, which is very good. And then just like really quickly, some people got confused with the red one. That one is describing, so like when you have your arms up like this, it's generally like a mediastinal obstruction. So like, for example, like a goiter, if that's blocking the, I guess the drainage of venous blood from your head and neck, you get all that redness, which is called pembedded sign. Okay, very good. That's the only other one that can be a bit confusing. The other ones probably make a bit of sense.
Yep. I did get a question about green. So that's tracheal tug, which I might be wrong. I think that's lung cancer.
Tracheal tug. That might also just be like fibrosis, right? It's like general
yeah,
severe respiratory distress as well. You get tracheal tug, and that's like crew in like young children, and I guess anything which causes respiratory distress would make that tracheal tug come out as well.
Yeah.
I think someone asked what blue is. Deviated nasal septum. I think that's just a mix and match. Like deviated nasal septum is more like a risk factor for obstruction of the airways, and then purulent discharge is like some sort of infection in the nose. So I kind of just put that there as a bit of a random mix and match.
Yeah. Easy. And so, yeah, I think I had a couple of people ask about green. So yeah, theoretically you could get that with COPD. I think the intent of the question is more like, which of these is specific for CO2 retention? And you'll come across a few questions like that in the exam where it's like, okay, best option. Good stuff. All right, let's forge on. Dyspnea on climbing stairs, but not at rest. I like the telegram sort of way I have to write the questions so that they fit in the word count.
Otherwise, we have to do the annoying thing like screenshotting questions.
Yeah,
and
exactly.
You can barely see the words.
I when I was writing this, I'm like, I'm not doing that again. So
yeah,
I shortened more or truncated.
We're past that.
Good stuff. Aston, anyone able to give me the triad? SAD, Aston? Three things. Yeah. Angina, syncope, dyspnea. Awesome. So this is just, pretty much classic. Excuse me.
It's just important to remember also with the dyspnea, it's exertional. So that's why in this case, it was exertional, but not at rest. So just keep that in mind, but well done.
Yeah. And so this is sometimes they'll chuck it as a distractor. It's like, is this a respiratory problem? No. So if you see something like this, it doesn't even need to be all three. You don't, like in this case, we don't have angina. But if the really keywords they love to throw in is like climbing the stairs, you get out of breath, and loss of consciousness in particular doesn't happen as often with respiratory stuff. And so that's more linked to valvular pathology. All right, we've had our first quintuple digits. Many more to come, hopefully.
I hope this histology question shakes things up a bit.
Yeah, hopefully. It'd be too easy. We're to go harder on you guys.
Yeah.
Good. All right, is this one of yours?
I did not write this. I might have been.
I don't mind explaining this one. I think it might have been mine when I did a bit of histology for respiratory system. So basically, the main thing here is understanding where the CO2 starts off. So it starts off in the vessels and the capillaries, and its goal is to get into the alveoli. So it passes through the capillaries first, and then the alveolar layers. So endothelium, basement membrane, all of that surfactant. I also think it passes through pneumocytes. Was it type 1? It might be. But type 2 is what that makes surfactant, or is it the other way around?
Type 2 makes the surfactant, if I remember.
Okay, perfect. Yeah. So it does pass through type 1, but not in the order which is given in the other ones. So yeah, that's why orange is correct. And I think blue was the one that was confused with. It
might be people thinking the wrong way, like they might just be confusing for inhalation.
Yeah, exactly. So you go capillary to alveoli. Orange is correct, and then blue is more so if it's oxygen going from alveoli to capillary. Yeah.
Yeah, and if you're confused about is there pneumocytes, are there basement membrane? Just remember, it always needs to if you're going from out to in, you always have to go through surfactant first and endothelium last. If you're going in to out, like CO2, you always have to go through endothelium first and surfactant last. So there can be different orders of stuff in between, but it'll always have to go through those two. And of course, the basement membrane will need to be between those in all cases. All right, bit of movement in the top 5. All right, we know this one. Bad luck to the people who said sputum sample. Yeah, throat swab, which you don't do because you're going to disturb the epiglottis, which is currently swollen and causing problems. Easy.
I think even like an oral temperature is not recommended because you just
Yeah.
like you put anything in the throat which is already so obstructed, it's going to make things worse. So just to keep
Yeah.
that in mind. Very good.
Exactly. All right. Newborn with AIDS. All right, good stuff.
I think that might have been me again with the respiratory slides. So yeah, pretty much what we talked about before with the type 1 and type 2 pneumocystis. Type 1 is the alveolar cells involved with the alveolar membrane and gas exchange barrier. Type 2 is more so involved with surfactant production. And if it's deficient, then you have deficient production of surfactant, reduced. So basically surfactant is responsible for reducing the hydrogen bonding between water molecules that line the alveoli. If that's not there, then it becomes overwhelming, the hydrogen bonding forces, and it causes the alveoli to sort of collapse in, and then they undergo respiratory distress syndrome, which is why the answer here is blue.
Perfect. Yeah, we've sort of laid the breadcrumbs there. So, if you have problems with breathing, probably surfactant. If we're thinking, some substance, and pneumocyte T2s, those are our guys. All right. Okay, CF bugs now. All right, good stuff. Yep. So like the reason we talk about this one so much is because A, it's just very common in CF people. And if you remember, that changes over time. I think we have a graph somewhere on our CF slide for like the different organisms. Strep pneumoniae, like you'll get respiratory infections in normal people. Staph aureus to a degree, Haemophilus influenzae to a degree. But P. oryzae is like just like really common in CF, and it's really uncommon outside of CF, which is why we talk so much about it. Be good stuff. We have a new leader for the first time in a while. Let's see. All right, we're just going straight into abdo, I think. Nice, good stuff. Did one of you guys write this one?
I think it may have been me. But I guess there's no better way to explain this than the fact that it's just something you need to remember. I guess if you want an easy way to remember this, or at least an easier way than just memorizing words, it might be good to look at the diagrams that were given to you in, I think you had Professor Michelle Lazarus for these lectures. I think she included like 2 diagrams of like the abdominal wall and like different color coding, and then another diagram of the testes going into the adult position, and then how all those walls contribute. One important thing to remember is that there is one wall that doesn't contribute, which is the transversus abdominis, but then everything else has some form of contribution in the scrotum. So in this case, it was internal oblique gives cremester. The other one to remember is external oblique, which is really easy. It's the external spermatic fascia. Yeah.
And I think we have video anterior abdo wall descent of testes. I think that should have something on this. Yeah.
Oh yeah, why am I not promoting our own videos? Like,
come on, stay in the brand, my man. Look, props to you for answering this so quickly, because I think I still don't know this. So yeah, well done. I think this is another sort of, you just have to memorize it. So the inguinal ligament is sort of like nowhere in the same place. So hopefully by the time you learn Hasselbach triangle, if you're able to locate it up in your epigastric sort of area, we will not be making that mistake. I think, yeah, it's sort of, yeah, sorry, clinical relevance, important. We're not just learning for exams here. But yeah, this sort of stuff is sort of, and it is a bit easier too if you understand the clinical relevance, because then it sort of sticks in your mind a bit more than it's just this random fact that I need to know for no reason.
Does anyone out of curiosity know why we care about Hasselbach's triangle? Just like in the chat, let us know what is like the pathology associated with it that we, unless someone's already mentioned it. Have you mentioned it already, James?
I have not.
Okay, perfect. It's already been said in the chat. Amazing. Directing inguinal hernia, perfect.
Easy. Also, that was totally, I completely lied when I said the inguinal ligament isn't close. That was just a brain fart on my part. So my bad. This one is high yield though. They love talking about this like so much, genuinely.
Yes.
Okay, bit of a spread.
Can we run through this one?
Yeah, please.
Yeah, so the arcuate line, I guess the basic thing to remember here is that above the arc, like, so you have the same muscles, right? Above and below. You still have external oblique, internal oblique, rectus abdominis, transversus abdominis, like all those muscles exist. The only difference is that above the arcuate line, the internal oblique splits on either side of the rectus abdominis. So rectus abdominis is the one that sort of just goes up and down. You have external oblique outside, internal oblique comes through, splits on either side, and then reconnects in the middle in the linea alba. Then you've got the internal oblique behind everything, transversus abdominis behind all of that. Below the arcuate line, it doesn't matter because everything goes to the front, nothing splits. So you just have external oblique, internal oblique, transversus abdominis, rectus abdominis, and then all the fascia, peritoneum, that kind of thing. So as long as you remember that and that diagram is sort of imprinted in your mind, and you have the idea of like below the arcuate line, everything goes in front, this answer should be fairly straightforward. So just make a diagram for yourself.
Good stuff.
But yes, as James said, very, very high yield. At least 1 or 2 questions on this.
Yeah. Look, I will say, surgeons, if you like get to clinical rotations in year 3, surgeons love asking you random anatomical stuff. A secret I will take to my grave, apart from I'm telling it to you guys now, is that one time one of them asked me like some weird niche anatomical question, and I answered correctly, and he was like, "Oh, that's cool, well done." And it was because the registrar had told me about that like 3 minutes prior. So yeah, shamelessly steal knowledge. That's our advice for you. One of these I will be very concerned if people pick.
Yeah, read the question carefully.
Okay, 7 of you people need to have a long, hard look at abdominal anatomy, because there is not, in fact, a recto-uterine recess in males.
Yeah.
But well done to most of you who I think we get the general idea. Vesicle means bladder. Like it's just sort of one of those things where things will just have multiple names for no reason. Like you'll also get the bladder get called like the prefix cyst will be used for the bladder, like cholecyst for the gallbladder, and then cyst for the actual gallbladder, like cystitis. You just have to get used to it. There's not really a trick to it, unfortunately. Yeah,
and the 3 like recesses that you have to remember, like the ones that are important, are all listed here. Just remember, rectovesicle is standing male patient, Douglas's pouch is standing female patient, and then Morrison's pouch would be any patient who is lying down. And then they might chuck in a few extra ones in the exam, but if you know these ones, they're the most important.
Yeah. All right. Going back to our axial sections, everyone's favorite part of anatomy.
I remember I was in a imaging session, and we were just discussing the transpyloric plane. And I think the tutor that we had, they were like, the transpyloric plane is so useless in terms of anatomy, and we had a whole session on just like what is happening at the transpyloric plane. I was like, why are we doing this if it's so useless? But apparently, like, you don't need to know anything about the transpyloric plane except for like the vertebral levels, because yeah, it's significant apparently.
Yeah.
I think with this one, I'm not gonna lie, like it's I don't think it's something that I remember like very well, but I think that essentially, remember the main things would be the second part of the duodenum, obviously the pylorus, so that kind of like they sort of match up in a sense. Then the origin of the portal vein, so the when the inferior mesenteric vein and the splenic vein come together, that's where you get the origin of the portal vein at this plane. I don't think it's the tail of the pancreas. I think it might be the head of the pancreas that's at this level. And then just remember the like L1, L2, that kind of thing, right? That's the main things you need to know.
Yeah.
I think there's a mnemonic somewhere out there, but yeah.
Yeah. Somebody asked why is it D2 and not D1? Because D2 is the bit that connects to the head of the pancreas. So that's where you get your sphincter body and all that sort of stuff.
Mm.
All right. This one's mean, but hopefully we'll be able to get it once you read. All right, I'm getting a good number of answers.
Yeah, people are fast on the buzzers for this. So I think that we all kind of know how this works.
Or not.
Oh, okay, never mind. So I think I may have, I'm just gonna make sure that this is not like, wait, common bile duct. Wait, is this
I think this.
oh no.
This,
Oh wait, no, it is correct, right? Common hepatic duct. Yeah. Okay, so essentially I think the difference between blue and yellow is the common hepatic duct versus the common bile duct. But if you think about the stuff that's going into the liver, that's going to be like the portal triad, and that's going to be liver associated things. So it's going to be hepatic artery, portal vein, and hepatic duct. The common bile duct only comes like much later as you go down. Okay, so like you have the hepatic ducts, you have the pancreatic ducts, you have the the gallbladder duct and that kind of thing, like cystic duct. They come together to form the common bile duct. So that happens later. The other thing that's confusing, so some people picked red. Remember that it's not hepatic vein that is actually part of this portal triad, it's the portal vein. So the thing that makes it confusing is the fact that there's a dual blood supply of the liver. So just keep that in mind.
Yeah, I'll say this is probably my bad with the question, because I think you can probably argue both. At the what I probably should have said is at the superior portion of the hepatoduodenal ligament, it's going to be the common hepatic duct, and then it changes to common bile duct by the time it gets to the inferior portion. So that's my bad. Because basically it leaves the liver as the common hepatic duct, and then like halfway through the ligament, it merges with the I think cholecystic duct from the gallbladder to form the common bile duct. So apologies on that one.
And the surgically significant bit is usually the superior edge. So that's the reason why this has been like, this is the answer. But for anyone who picked yellow, don't be disheartened. Like, you're on the right track.
Yeah, that's on us. And yeah, somebody said Pringle maneuver. Yes, this is the bit you do the Pringle maneuver on.
Yeah, nice.
So that's you stick your finger behind there and you use it to dissect stuff off. Easy. Okay. Foul smelling greasy stools. Bonus points if you can chuck in chat what the name for that is. If somebody said steatoria, perfect. Good stuff.
I like there's two for that here.
I think we might have messed this one up too. Yeah, that might be.
Can I go and explain that?
Yeah, go ahead.
Yeah, sure. So pancreatitis and cystic fibrosis are both causes of fat malabsorption. Pancreatitis because you're not producing the relevant enzymes to break down fat from the pancreas. Cystic fibrosis because it sort of clogs your ducts that are going to be responsible for sending out those enzymes into the digestive tract. Either way, you have a reduced absorption of fats. So the fats stay within the stool, making it greasy and smelly. And I think also it floats in the bowl, but I'm not too sure why we haven't got the yellow one there as well. I think it should be both of them.
Yeah, I think that might just be an error in copying it over. So our bad on that one. But yeah, basically CF and pancreatitis, thinking about fat malabsorption. So why is there fat in the stool? Because it hasn't been absorbed earlier in the digestive system. Okie dokie. Okay, good. So we're all sort of on the right track here, or at least most of us. The basic idea is that the CCK is what is going to loose all of our bile into the duodenum by relaxing the sphincter body, and at the same time, it's going to release pancreatic lipase, because that is also a major sort of avenue of fat absorption. So yeah, this is again just something that you sort of have to learn, but yeah, very good to know. So well done to those of you who got it. Right, going up to the upper GI tract now. Yep, good stuff. So dysphagia is pretty multifactorial. There can be a lot of things that cause dysphagia. In the case of achalasia, it's a nervous problem. And so basically that's just important in terms of management. So, you know, depending on what the actual problem is, we're going to manage it in different ways because we have to treat the problem. But yeah, good stuff. All right. Intrinsic factor. I think this question, it was intended as a GI question, but it also doubles as a nutrition question.
Nutrition, by the way, is a pretty important subject. Don't just ignore it. Like, there will be questions on it.
And watch our video on it that we put out like 3 days ago.
And you'll come to learn it's also a very important heme question as well. Yes.
Good stuff. So yeah, parietal cells. Remember, it's parietal cells. I think pretty much all of us knew that it was B12, so that's really good. And yeah, I think I'll hold off on explaining too much more about B12 because I think we have more questions about that towards the end, and we'll do a more in-depth explanation of it then. But good stuff. And wait, correct me if I'm wrong, but parietal cells also hydrochloric acid, I think?
Yes, and chief cells pepsinogen.
Yeah.
That's pretty much your whole set of chemicals you have to know in the stomach.
Pretty confident this one.
Yeah, I think I kind of gave that away with my previous answer as well, but you're right in that pepsin or pepsinogen, which is the zymogen or the inactive form of that, is secreted by parietal chief cells of the stomach, whereas all the other enzymes there, trypsinogen, amylase, carboxypeptidase, they're all digestive enzymes produced by the pancreas. That's all you have to really know there.
Yeah, I mean, this is like a bit of a long shot. If you guys did bio 3-4, you might remember that, which is like also 2 years ago for you guys now, but you might remember that they always talk about pepsin because it's the one that works well at low pHs because it's in the stomach. So pepsin is like this massive outlier because all of these other enzymes are meant to work at like either normal body pH or basic, because that's what the duodenum and most of the rest of the gut is. But pepsin does its work in the stomach, and so it actually operates at really low pHs because of all the acid. Also, like, you know, like peptic, pepsin makes sense, I guess. Right. Thinking about, so this is all like, these will also result in dysphagia and identifies if there are abnormal constrictions.
Yeah, well done. So with this one, essentially I know it's annoying to have to remember all these fine details, but it's very important when it comes to impaction of food or like similar, like if you have, for example, a cancer growing in the esophagus and it's at one of these constrictions, then it can lead to even more, I guess, dysphagia because things are not going to be able to go through. A similar thing is really important when you get to kidneys. So if you think about the normal constrictions of the ureters, that can be places where your kidney stones are most likely to impact, and therefore the pain distribution is going to follow that particular physiological constriction. So with the esophagus, just remember A, B, C, D. Arch of the aorta is A, left main bronchus is B. And I think, I'm not sure if there was a question in the chat about left and right bronchus. I think the left and right bronchus are not symmetrical. One is higher than the other. So specifically, it's the left main bronchus that you have the level at. C is not just for cartilage, it's cricoid cartilage. So I hope that makes it a little bit easier to remember. So it's not thyroid, it's cricoid. And then diaphragmatic hiatus, which makes sense because it's going through this massive muscle. So it has to constrict a little bit.
Yeah.
Well done.
And I'll add with the bronchi. Remember that the stomach is at the left side of your body, like it's not centered. And so the esophagus has to make its way over there eventually. And so it's sort of two things of both, we have a different respiratory tree shape, and we have the esophagus going over there, and they sort of combine to result in that constriction.
Yeah, good point. Yeah.
Right. Should be just be large intestine, I think.
Yeah. Unless you have two, I don't know.
That's probably a birth defect. I wonder.
Yeah. Embryology, like I guess anything can happen.
I can only remember the kidney ones because there's the hockey puck one.
Oh yeah, and the Kahoots. Just like anything can happen with the kidneys.
All right. So running through these, we don't have circumferential castrations. The splenic factor is on the left-hand side because your spleen's on your left, your liver's on your right instead. More centrally in abdominal. Actually, don't know about that one. I didn't write this question, so I'm just guessing.
Yeah, so I think with the last one, generally, like very generally speaking, small intestines are more centrally, like just anatomically makes sense, and then large intestines are peripheral. But the reason why I put in the yellow one as well is because when you get things like bowel obstructions, you might learn about this more in third year. Like your intestines kind of just go all over the place because different parts are distended and different parts are not distended. So sometimes that's not a reliable way to differentiate. The more reliable way is to look at either the haustrations in the large intestines, which are not circumferential, or in the small intestines, you can see these things called plicae circularis. And there's another name, which I don't remember at this stage, but plicae circularis, which is circumferential. Or I think it's called valvulae conventae or something like that. So if you remember those, that's another easy way to remember the difference. Circumferential means that it goes around the whole bowel loop, whereas haustrations don't go around the whole thing.
Yeah, so if
it's an easy way to differentiate.
Yeah, if you look at a diagram, you can see the Taenia coli sort of splitting the haustrations as you go all the way down the column. And so it's just they don't go all the way around. The other time, this is long shot, but the other time where circumferential is a word that you'll see is in cartilage, when we talk about the respiratory tree. And so you can remember, I think in pretty much no part of the respiratory tree, except maybe the trachea to some extent, do we get circumferential cartilage. Yeah. All right, dentate line. Neoplastic growth would be that'd be really bad. Like usually we're talking about hemorrhoids.
Yes.
Good stuff. So yeah, this one really like exemplifies why we talk about the dentate line. So red visceral sensory innervation. Well, it's not visceral sensory innervation because it's below the dentate line. And so it's actually, I'm drawing a blank on the word because I'm dumb. opposite of visceral, somatic.
Somatic, yeah.
So we get that instead because it's sort of associated with the skin around the area rather than with the internal organs. Same thing, it's not derived from endoderm, it's derived from ectoderm because it's associated with the skin. It will drain into I think the perianal lymph nodes, and then into the superficial inguinal lymph nodes or something like that. I'd need to double check that. But yeah, point is, it's definitely not internal iliac nodes because that is the sort of large intestine, the rectum, the stuff above the dentate line, basically. And so it's just sort of internal, external is really the way to think about it. And a lot of the names will help you out because they'll be internal or external or superficial or whatnot. Okay. And yeah, so no portal venous system because the stuff above the dentate line does drain into the portal venous system. Whereas the stuff below it drains into more superficial veins. All right. Okay. So yeah, just I guess the thing to remember. So your bilirubin is what we have in our liver. Biliverdin is the intermediate stage. Also, we basically find in the liver. Urobilin is what we get like a little bit of excretion through the urine, and then stercobilin in the poo. Basically, we get a lot of excretion. And so that's just a case of you just have to remember it. And that reflects back with jaundice. So if you get a lack of bilirubin, then you get pale stools, and you get because there's no stercobilin, because it's what makes stools brown, and you get a excess in the urine, and you get and dark urine basically. Okay. Try and pick up the pace a little bit because I think we're going. That's right, we're going to go pretty long. But we'll definitely be finished before 7. Probably like 6:37, 6:45. I don't know, somewhere in that range. All right, this is our second asterisk question. So you can get it in severe CO2 retention. You can also get it in liver disease, which is why we also sometimes call it hepatic flap. Dupuytren's contractures, that's like chronic alcoholism, sort of cirrhosis, which is sort of more of a different angle on liver disease. Xanthomata and xanthelasma, cholesterol, dark velvety patch. I don't know if that's talking about acanthosis.
I think that's for acanthosis nigricans for insulin resistance.
Yeah, that's what I thought.
Type 2 diabetes.
Yeah, easy. Okie dokie. This one's a bit of a deep cut, but very good if you know it. All right. We all know this one, so I'm not going to label the point too much. PBI because we want to deal with acid, amoxicillin, and clarithromycin to kill our little bugs. All right. Thinking about our different types of laxatives, basically. Okay, I didn't write this one. Did one of you guys?
I think with this one, it was just that the fact that they have a bowel cancer. So if we try and give them like a really strong laxative, it's going to probably worsen. Like you're just like pushing against an obstruction, and then you get things like toxic megacolon, which is not good. So in like, I think Docusate is a fecal softener. So it's not a very strong laxative, but it'll just soften the stool so that it can go past whatever lumen there is for it to go past. So that's why it's more safe, I think.
I think also two of the other ones are active, like they actively cause the gut to try and put more water into the bowel and like sort of move the feces out, which you kind of want to avoid when you have already damaged bowel in the context of cancer.
Yeah. So one thing you'll see in practice a lot is Docusate Senna, which is a combination of Docusate and Senna, which is a stimulant laxative. And so they'll, two different mechanisms. Usually they'll work together pretty well, but you have to be careful with certain patients. Okay, 5-HT receptor blockers. Okay, well, we're pretty good with our 5-HT receptor blockers apparently. Good stuff. And yeah, this one's pretty straightforward. Yeah, what's the other name for 5-HT? Important to know, because they might not give you a 5-HT receptor blocker. Serotonin, good stuff. Yeah, pretty straightforward. Ondansetron, you should always remember as that. And then it's good to know in general all of those different pathways to acid formation, because again, there's sort of different things of the different types of blockage we can have, which sometimes if we know the cause of, say, ulcers, we will go for a certain one. Whereas in other cases where we just want to block things, we'll go for a PPI, because PPIs block everything, because they're blocking at the hydrogen ion part. Right, this one is absolutely classic. So I hope we've all got it. Good stuff, yeah. So a few people went for red. The reason we wouldn't get fever and chills is because those are more systemic. So that means the infection has gone up and it's like more in your actual body. Whereas with a lower UTI, something confined to the lower urinary tract, we'd expect to see only stuff that is related to the urinary tract. So super referred pain, dysuria, because of course it's going to stimulate things down there, and then frequency. Okay, and then flank pain, and vomiting, those are, you're just looking through blue and green, those are also symptoms of pyelonephritis, which is basically an upper UTI. And so really the symptoms come down to thinking like, is this the body has got something wrong with it, or just the urinary tract? Pis-en-deux, very memorable name for a symptom. Okay, good stuff. So yeah, pretty straightforward. Pis-en-deux is you have to go again soon after going the first time. So you didn't empty properly the first time. So you have to think about what is going to stop you from urinating properly the first time. And that comes down to obstruction of the urethra. And that can either be just straight up obstruction, so, like a urinary stone or something, or it can be BPH, which is option yellow there. Inflammation of the, see, if red was inflammation of the urethra, then that would actually probably work. But in this case, because it's the ureters, those are too high up to actually affect any micturition. And so those wouldn't manifest in that way. Overproduction of urine, that would just be frequency and polyuria rather than pis-en-deux. All right, leukonychia. Somebody was very quick on the draw. That was like the moment I opened it up.
Yeah, nice. I think with the it's interesting because like a lot of these examinations, like obviously with respiratory examination, cardio examination, that kind of thing, like the main focus is the chest, and then with abdo, the main focus is the gut. But for what it's worth, like there's so many things on the hand that you can look for and that you need to start off with, that like it's really important that you know these really small individual things. So with like leukonychia, what you essentially get is you get these white spots on your nails, and most of the time it's something as benign as just like some sort of like trauma. So you get nail biting, or you have something falling on your nail and then you get a white spot. But in rare cases, it can be because of a low amount of albumin in your blood, which is secondary to some sort of kidney problem. And remember that nephrotic syndrome is the one that leads to you getting rid of a lot of protein in your urine, whereas nephrotic syndrome is more to do with like blood, I think. So that's why it's nephrotic syndrome. With anemia, especially like iron deficiency anemia, there's also a specific nail sign. Does anyone know what that might be? Like, what is that called? Yes, koilonychia. So spoon-shaped fingernails. Very good.
Some good stuff. All right. Oh, this is a histology question. Again, very quick. All right, good. We're all pretty much on the same page. So basically, if you look at the image, so there's a few different structures that look like this. You know it's not going to be a glomerulus. That's the thing to the left. It's huge and it looks nothing like that. It's not going to be a loop of Henle. That's much more sort of linear. So we're sort of tossing up really between DCT and PCT. And the reason we would say this is a distal convoluted tubule is it doesn't have that really brush border fuzzy boundary that we expect to see with a proximal convoluted tubule. So well done to all of you who got that one. All right. Can somebody unseat our leaders? We'll find out. This one, again, annoying, but it has come up. And knowing med faculty, that means that it's almost guaranteed to come up again at some point. So hopefully you guys know this. Good stuff.
Well done.
Yeah. Again, you just sort of have to memorize it basically. You can do a little bit of like, well, segmental has to be near the top because it's, you know, those are the really big, large macro parts of the kidney. But really it comes down to, you just need to learn the sequence, which is true of a lot of stuff in anatomy. All right, these drugs, plural should be. All right, so yeah, these drugs are basically quite bad for you because, well, bad for your kidneys at least, because they make them much less effective, and it's because of what they do to the nephron. So your NSAIDs, they constrict the afferent arteriole, the one that brings the blood in, and ARBs dilate the efferent arteriole. So you can think of it as like, you know, instead of being a funnel, where we're going from, you know, a normal temperature to we're sort of building up pressure in the nephron, in the glomerulus. We're now doing the opposite. We're actually losing a lot of pressure in the glomerulus, which means that the pressure balance between the Bowman space and the actual interior arteries, capillaries, is just gone. And so you want to build up a lot of pressure, and you do that by having a nice constricted efferent arteriole. So if you put those two together and then you add diuretics, then you're basically just losing a lot of stuff and not properly filtering your blood. And that's what we call the triple whammy with renal function. Good stuff. Looks like most of us got that to some degree. Now, speaking of diuretics, okay, we're very comfortable with potassium-sparing diuretics, which is very good. Good. None of your patients are going to get hyperkalemia. They'll all be very happy with the potassium balance. So yeah, thiamide is, sorry, hydrochlorothiazide, shockingly, is a thiazide diuretic. Furosemide is a, I think both furosemide and indapamide are loop diuretics. And so none of those are potassium sparing. Good stuff. And so, sorry, the clinical relevance of that, just while we're getting to the next question, is that you don't want to use a non-potassium sparing diuretic long-term. You want to use something like spironolactone long-term, because otherwise you just slowly get problems with potassium. All right, sorry, somebody, my previous explanation was very quick because I was trying to fit it in after clicking start, rookie mistake. Non-potassium sparing diuretics, so loop diuretics and thiazide diuretics, they make your potassium go out of whack. That is bad in the long term, but it's like okay acutely. So if someone comes to the hospital, you can give them furosemide. But if we want to put them on something long term, we want to put them on something that doesn't put their potassium out of whack. So spironolactone doesn't work as well quickly as furosemide, but it's better long term. And so we'll put somebody on that for, like, you know, discharge home. In terms of strictures of the ureters, your pelvic rim is like an important place that you'll get it. I think the others, I actually can't remember the others right now. One is the
pelvic-ureteric and vesico-ureteric are the other two. Basically just where it exits from the kidneys and then where it enters into the bladder. That's it.
Good stuff. Prostate and IUS and EUS, that's all like urethra stuff. So it shouldn't really be anywhere near the ureters. Yes, and yes, very relevant for renal stones because that's where they're going to get lodged. All right, bicarb reabsorption, important for acidosis and alkalosis. All right, yeah, not too much to say for this one. It happens in the PCT, and that's where it happens.
It's kind of like with microbiology where like, like if you don't know what the answer is, just go Staph aureus. Like it's similar with this. The PCT is pretty much where most of the absorption and secretion stuff happens. So yeah, essentially just pick that if you're not sure.
Yeah. Oh, this one, don't calculate. I don't want to see anyone getting those ratios out. Just look at the numbers and try and think about it. Okay. I think DCT is only like water, isn't it? Or am I wrong? Or is that collecting tube? No, collecting tubule is definitely only water. DCT might be something else. Yeah. Getting my wires crossed. All right, we got a good amount of answers here. Hopefully they're right. Oh boy. Oh boy. We have some differences of opinion here. Okay, so in terms of how we work this one out. So our sequence should always go, first of all, what's the problem? So we know it's an acidosis because you know, the pH is low. The next question is it metabolic or respiratory? And what, like, literally all that comes down to is you look at the numbers and you say, okay, which one of these is off in the correct direction to cause the problem? Okay, so our PaCO2 is down. That would cause alkalosis if that was the main problem. So we know it's not actually respiratory related. Bicarbonate is down. That would cause acidosis if that was the problem. So we can say it's a metabolic acidosis. So well done to people who got red and blue. Then beyond that, Compensation, again, you can have a lot of different ratios. In the end, the most important thing to determine compensation is, has it shifted? And in this case, we have shifted. So we've seen the body shunting out more carbon dioxide in order to make up for the low bicarbonate, okay? So yeah, that's the basic idea. Again, reference ranges, so 7.35 to 4.5 for pH. PaCO2, I think it's 35 to 45, and HCO3, 22 to 26. So yeah, again, remember, the most important thing with this sort of stuff is just to like think what is causing the problem and what is trying to fix the problem. And they'll never be off in the same direction. Oh, if they are, maybe it's like, you know, really bad, uncompensated, but yeah. All right, 16 questions left. Anyone could win, potentially. I'm not sure they'll actually give you ECG questions. I think this is potentially just being mean to you for no reason. But if they do, you guys will be.
It has come up in past papers, so it'll help you to at least answer those questions. Yeah.
Perfect. There you go. So they might throw it at you anyway.
Yeah.
Okay, we're a bit split between AV type 1 and AV type 2. So let's look at the media. Well, I'm glad that nobody said first degree AV block because, you know, we dropped a beat, so there's something happening here. And third degree AV block also no, because we can see that there is some correlation between P waves and QRS complexes. Okay, so third degree would be no correlation, first degree would be just a delay. So between type 1 and type 2, the difference is in type 1, it gets longer and longer and longer, and then it drops. In type 2, it just drops on some regular schedule. Okay, so here what we're seeing is that there are 2 beats. There's not an increase in PQ interval, or sorry, it's still PR interval, in PR interval, and then we get a drop beat out of nowhere. Okay, so that has to be a type 2. If it was a type 1, we'd have to see at least some increase in PR interval, and we've got like 5 P waves here, and they've all got the exact same PR interval, and so it can't be a type 1. Okay, awesome. Ooh, a lot of movement on the top here. Calcitonin, this is straight on to endo. This I might have gone too easy on you with this one. All right, good stuff. So yeah, calcitonin, we get less bone resorption, meaning that we get less calcium in the blood, basically. And so you can contrast that with parathyroid hormone, basically.
A bit of a histology question as well. Does anyone know which cells make calcitonin, and also where those cells are located in the thyroid gland? You can answer that in the chat. We'll just go past this question. Yeah, perfect. Someone said parafollicular, C cells, perfect. So like in histology, you'd see that as being between the lobules, where the C cells are located, sort of the intersection of like the space between them.
Good stuff. All right, we're talking about rank ligand now. Okay, good stuff. I'm glad that very few of us went for red and green because osteoblasts make bone and osteoclasts resorb bone. And yes, a rank ligand, when it is allowed to act, it increases bone resorption. And so that's why we sometimes have blockers against it in osteoporosis, because we want to prevent you eating away your own bones, because we want to make them as strong as possible. Okay. Next question. IGF and growth hormone. Oh boy. Okay. So we've got a bit of a split here, but that should say gluconeogenesis. Basically, the idea is IGF-1 does like almost everything for growth hormone. Like you look at the function of growth hormone, and like 90% of them are basically just IGF-1 does this. The main effect of growth hormone that it does itself without relying on IGF-1 is fat cells. So it goes to fat cells and it increases lipolysis. Almost everything else is an IGF-1 issue. Yeah, and that's sort of the main thing. So go and revise the HGH. I think we talk about that in the hypothalamus and pituitary glands videos, which is also a good endo overview in general. So yeah. Also, yeah, bonus, anyone chuck in chat the name of the disorder we get when we get too much growth hormone, usually in adulthood.
And side note as well, I think the other effect besides lipolysis is increasing blood glucose, which kind of makes sense because if it was insulin-like, it would try and decrease blood glucose. So it's like the opposite effect from the different pathway, which is not IGF-1.
Yeah. All right. Bonus question in chat. Anyone able to tell me the other name for ADH? But yeah, so glad that we didn't go for the parvocellular nucleus. That's where parvocellular nuclei are where we get the anterior pituitary, the stuff that acts on the anterior pituitary. The paraventricular is where we get oxytocin being produced, and then supraoptic nucleus is where we get ADH, also called vasopressin. Thank you, chat. Alpha cells of anterior pituitary, that's just our actual pituitary hormones. Remember that the posterior pituitary isn't really a gland. It's more just like the exit port for all of the stuff that we get from the hypothalamus that doesn't go to the anterior pituitary. It's a fascinating little gland, that one, actually. All right. We have an adverse drug reaction, but what drug? All right, good stuff. So yeah, the central obesity and the easy bruising are a pretty big giveaway for this one. So it's going to be hydrocortisone, because this is a basically, I think Cushing syndrome, I think is the term that we're meant to use for the drug effect. There's a few different overlapping ones like Cushing disease that you need to understand. Perindopril and valsartan have almost nothing to do with this. They're ACE inhibitor and a ARB. Respectively. Meloxicam is I think, joint anti-inflammatory drug. And so none of them have any effects that have to do with Cushing's. All right. Acute ketoacidosis, what are we going to do? Interesting. Okay. So basically, in a case of acute ketoacidosis, the problem here, 99% of the time, is this is a type 1 diabetes patient where things have gotten out of control. Okay, so the insulin levels have dropped, and like the most important thing for them is to get the insulin back up. So IV dextrose is not really going to do much for them necessarily. Maybe there's a bit of fluid resus to go on there if they're in shock, but insulin is the thing that they actually need. And so yeah, DKA, very common presentation, stands for diabetic ketoacidosis, and it's like pretty much always a type 1 patient. So that's a good one to know. So have a revise of your diabetes, because it comes up a lot, which is because a lot of people have diabetes. SGLT2 inhibitors. Speaking of diabetes, more diabetes drugs. Good stuff. This question's like 90% because I always found it really annoying that sitagliptin sounds like it should be a SGLT2 inhibitor. It's like got like all the right letters and it's not at all. But yeah, all your SGLT2 inhibitors have like gliflozin at the end of them. Metformin, anyone remember the drug class for metformin? It's sort of the, yeah, biguanide, a couple of people have said. Yeah, so metformin is a type of biguanide. And it's a very common drug we use. SGLT2 inhibitors are quite good, by the way. They're sort of a new drug, and they have to do with the excretion, basically, in the kidneys, rather than metformin, which acts on the body in general. Okay, histology, adrenal glands. Okay, good stuff. Yeah. Okay.
So this is like doing histology. Again, you can go to the effort of like looking through the content and remembering all of it, or just like remember it with simple mnemonic. I think what was taught to us was GFR. So that's the order of the layers. You have zona glomerulosa, zona fasciculata, and zona reticularis as your 3 layers from outside to in. And then the other mnemonic you can remember for different functions of it is salt, sugar, sex. And the outermost one is responsible for salt. So that's like your aldosterone related stuff. Sugar is your middle layer with the fasciculata, which is cortisol related stuff. And then your inner layer is sex hormones like androgens. That's the way you can remember it. Yeah.
And bonus for that one, anyone chuck in chat, what gets made in the medulla of the adrenal gland? Because we've been talking about the cortex all this time. Yep, somebody said noradrenaline, adrenaline, good stuff. Yep, also known as epinephrine and norepinephrine. All right, voice hoarseness, bradycardia, hypothermia, reduced appetite. Which gland is responsible for this pathology? And once we're finished, anyone able to tell me which type of pathology this is? All right, good. Thyroid. We're all pretty confident in that. Yep, everyone's saying hypo. Good. Hypothyroid. So the classics is like bradycardia and hypothermia, because like you think it's like slow heartbeat, cold. It's like the opposite. Like hyperthyroidism, you're like overheating. You know, your heart's working really hard. You're really hot. You have a lot of appetite because you're burning up so much. Whereas like, you know, hypothermia is almost, sorry, hypothyroidism is like you're almost hibernating. All right, good stuff. Some thyroid hormone tests. Oh boy.
That
Okay.
doesn't seem right, unless I'm reading it wrong.
Yeah.
I think it should be blue. Yeah.
Yeah. I mean, I think this should have been a multi-choice.
I can go on and explain this one.
Yeah, no, sorry, no, yeah, this is not a multi-choice. Yeah, just should be blue. I think we just picked the wrong option there. Yeah. Well done to people who picked blue.
Yeah, so the reasoning was for blue. I think the abnormal hormones are high T3 and T4, which are produced by a thyroid gland. So we're thinking because the TSH and TRH are not correlating with that in the sense that they're not high as well, we think it's probably a problem at the level of the thyroid gland, so primary hyperthyroidism. And then that would be caused by something like Graves' disease, Hashimoto's would be hypothyroidism. So that's the reason why we go for blue. And the reason we actually get low or reduced levels of TSH and TRH is negative feedback. With red, you'd expect there to be high TSH and also high T3 and T4, but low TRH. Whereas with green, you get everything being high.
So yeah, basically like you have to localize the level of the problem, and then everything above that will be trying to fix the problem, whereas the stuff below will be affected by the problem. So yeah, what it should be, what red actually would be, is high TSH, probably high T3 and T4, and then low TRH, because the body's like telling the hypothalamus, why are you making so much thyroid hormone? And the hypothalamus is saying it, but it's not me. Whereas the TRH tumor, you probably just have high everything. Hashimoto's, that's primary hypothyroidism. So the problem is at the level of thyroid, low T3, low T4, and then high TRH and high TSH, because it's saying, you know, why aren't you making more thyroid hormones? We need to make more. Awesome. Okay. Yes, back to nutrition. Recommended daily intake. If you guys have watched that video, I hope all of you get this one correct. Oh boy, 10 of you are in deep trouble. So yeah, recommended daily intake. It's basically like, another way to think of it is like, what will not get you sued if you tell your patient this, okay? And so you want to be as safe as possible. So recommended daily intake is like, it's the safest number to tell anyone ever, because it should work for everyone all the time. So red, amount that meets half the requirements in nearly all individuals. That's not actually a term, because like you can't meet half your requirement. Like that doesn't make much sense. Blue completely meets the requirements of half of individuals. That's I think estimated average requirement. Which is not something you tell patients, okay, because it's not useful to them, because they don't know which side of the bell curve they're on. So instead you give them the recommended daily intake, which is the covering your butt number. So it's very high. Good stuff. Look at these scores, stratospheric. All right, hypercholesterolemia. Okay, yeah. So like I said in the video about this one, the nutrition one, basically the cholesterol you have in your diet actually isn't that important compared to fatty acids, in terms of what your actual cholesterol in your body does. And so I'm glad nobody picked blue. Those are the worst ones for you. And so the more unsaturated the fatty acids are, the better. And so your monounsaturated fatty acids, they are kind of helpful for hypercholesterolemia. And then your polyunsaturated fatty acids are very helpful for hypercholesterolemia. Yeah, this is all your Mediterranean diet stuff. But yeah, good to remember. Ooh, some last minute movement. There's still a chance. Pernicious anemia. Very high yield. Okay, so good to talk about this one. So red, lack of dietary iron. Anyone able to tell me what that would cause? It's in the name. Yep, I've got a couple of things. So I'm getting iron deficiency anemia and microcytic. Good. So yeah, iron, so lack of iron, you get, as the name might suggest, iron deficiency anemia. And iron deficiency anemia is microcytic, okay? Which is like a lot of different anemias are microcytic, but nutritionally, the one that you need to remember is iron. Pernicious anemia is B12 and folate, okay? And those two, like that is like pretty much I think the only cause that you really need to know of macrocytic anemia. The basically pernicious anemia is you destroy parietal cells in the stomach and they can't make intrinsic factor. And without intrinsic factor, you get no B12. No B12, you get no folate, and no folate, you get macrocytic anemia. And so that's how pernicious anemia happens. Somebody asked, what does macrocytic refer to? It's the cell volume of the red blood cells. So in iron deficiency anemia, your red blood cells are sort of like very small and shriveled up. In macrocytic anemia from B12 and folate, you get very big red blood cells. So it's really important to remember like that mechanism. So pernicious anemia, you get autoimmune destruction of the parietal cells, and then that sort of cascades to intrinsic factor to B12 to folate. And then also when you have a patient with pernicious anemia, it's important to make sure that you check if it is a, because you could also, there's an outside chance if you have just sort of a macrocytic anemia not confirmed as pernicious, there's a chance that it's just a folate problem. And so if you, but if you treat them for folate only, then the anemia might get better, but they're still going to get symptoms of B12 deficiency if the problem is further up the line. And so you always got to check to make sure that the problem isn't further up the line before you start treatment for macrocytic anemia. Good stuff. Chronic inflammation of the terminal ileum, that might cause a little bit of B12 deficiency, but it's not pernicious anemia because B12 gets absorbed in the terminal ileum. And then excess of intrinsic factor, you'd get more B12. So it would cause the opposite of this problem. But yeah, good stuff. Oh, last minute overtake. Absolutely insane stuff happening here. This is a very important question, this one. Very high yield. Is that all three, any three of these, on their own could be a question in their exam, if you think about it. 13 of you are non-believers. I'm very disappointed. But yes, the other guys, well done, well done. Yeah, look. So look, I'm a bit concerned that yellow got the most. I think that says something maybe about our cohorts. Then again, I did write the question. But yeah, look. The integrated medicine, I think, is probably the hardest to study for, hardest and easiest, because the stuff that you can do is look at past papers and they will reuse half of those questions word for word. But then outside of that, they'll just bring up some random stat. I would say basically the bottom line is don't spend more time on it than it needs to. I'd say the easiest way to do it is just to incidentally revise it as you revise past papers and that sort of thing. Setting out and trying to go through those slides and just sort of like brute force it, not a good use of your time, especially this close to the exam. But yeah, and then our final question, also very important, high yield. Dethroned at the very end because you didn't believe in integrative medicine.
I think we have a question in the chat as well, James. Oh. Should I address that?
I will address
that. Already started the next question?
Yes.
Okay, we'll answer after this question.
We get our affirmation out of the way first. Awesome. Okay, good stuff.
Nice. Why is yellow correct? Why would you be salty about the Kahoot?
we're just trying to be supportive of people who did poorly in the Kahoot.
Fair. That's fair.
But well done. Yes, don't stress about it. It's year 2. It's all formative in the end, even when they say it's summative. And the most important thing is to learn your stuff and get out of here and be good doctors. And that doesn't correlate to your exam score unless you get a really bad one, in which case makeups.
Yeah.
But yes, I'll tell you what, we'll answer that question maybe after we do this, because I think we'll get out of the way and let people go if they have stuff to do, because like exams are in 4 days or something. So well done. Yeah, if only you believed in integrated medicine, I think you would have been first place. But well done to our winner. Smiley face.
Well
Excellent.
done.
Good. Yeah. Thanks everyone for coming. Stick around if you have questions. So we'll stick around for a while and we'll just answer any questions you have, including the one in chat right now. Other than that, have a great day. Revise, don't stress, and yeah, have fun with it.
Thank you.